Hi, folks. This is John Adamson, the Rehab and Documentation Guru, and it's a rainy Friday. And I figured I'd bring up a case study because this is an interesting topic to me and getting more into the clinical rather than compliance and documentation realm. So I have a patient. She, let's just say, is above retirement age, and she has a long-standing history of diabetes and MS. And I'm going to talk about the correlation of those two diagnoses for a moment. Both diagnoses suggest inflammatory processes, and if you know anything about the etiology of diabetes, you'll know, especially for type 2 diabetics, they generally have a condition called hyperinsulinemia. So they're producing more insulin than they need to because they are insulin resistant. So some type 2 diabetics also get more insulin on top of that to drive the insulin into the cell. And that, of course, just perpetuates part of the problem. So they've got inflammation. Well, inflammatory processes also can contribute to the sclerosis of the myelin sheaths of nerves. So I'm not surprised that this patient has both diseases. And I'm working with her primarily because of exacerbation related to her MS, but she's very stable now. But she's also got this problem with diabetes. And we've been working on, trying to strengthen her and get her better for transfers and pre-gate activities. And it's not going as well as I'd hoped. Part of the problem is she has both lower motor neuron and upper motor neuron symptoms in her legs. So lower motor neuron, not going to do much there. Upper motor neuron, we obviously have some blockages of some nerves to the legs, but we still have some intact motor neurons firing into the muscles of her lower extremities. I know that just from testing her muscles. So my hope is that she'll learn to recruit more muscle fibers with proper training, recognizing that she is at risk for extra fatigue due to her MS. So what happened today? And this is where I want to get into kind of a case scenario. I was going to retest her on strength training, and I'm using a functional strength assessment. She didn't do so well, but I saw her early in the day, and as I was working with her, I just talked about getting better subjective reporting from our patients, and I should have known better, but I started talking to her more and more, and we were talking about sugar, and she said, yeah, my sugar level was 123 this morning. So I did not take my insulin because I was talking to her about insulin and its role in inflammation, and we were talking about how she needs to lose some weight and that'll help her function. And anyway, she said, yeah, my sugar was 123, so I didn't take my insulin because that's a level where my sliding scale of insulin does not start. And she said, yeah, and I'm feeling kind of like a dish rag. Now, 123 blood sugar. For you and I who are non-diabetic, we should be feeling like champions ready to go out and conquer the world with the sugar starting off that high. We should be able to have plenty of energy for exercise. But if you're insulin resistant, meaning that the glucose that's needed in the cell for production of force generation for muscles and for other cellular processes, that's a low sugar for a person that's been insulin dependent for a long period of time. And so she's not feeling herself. She said, I feel like a dish rag today. So what I'm going to start having her do is about a half hour before my scheduled visit, I want her to take her sugar, and we should be doing this with patients anyway, take her sugar. And, if it's a little bit on the low side, not to be afraid of getting about 15 grams of carbs into her system with maybe some protein for a little bit more slow release of that glucose into her system. That way she has more energy when I get there, which is going to correspond with probably better muscular performance. She noted that yesterday, her sugars were higher yesterday, and she was like exercising like gangbusters doing her home program. So clinically, when I'm looking at measures and the fact that she didn't do so well today, I would automatically think, okay, I'm not making progress, and I've got restorative goals. Therefore, probably therapy is starting to look not medically necessary. But then when I correlate it with her comorbidities, including her diabetes, and I say, here's a correlation I can bring up to Medicare that has impact on the patient's therapy, and I'm demonstrating my knowledge of dealing with this diabetic condition and discussing this with the patient to hopefully yield a better outcome in the future. That is skill, or at least I hope it is. If we're dealing properly with our disease processes, we are demonstrating skill. And I was telling the patient, that's the kind of information I'd like to get from her, because that information will separate me, and how I respond to that information will separate me from Joe Buffschmo, personal trainer down in Planet Fitness without a fully developed prefrontal cortex. Anyway, I hope that was helpful. If you have any ideas for case studies, please feel free to send them along, especially if you have clinical expertise in a certain area that would help the general therapy community better treat their patients, for one, and secondly, demonstrate skill in their documentation. John Adamson, the Rehab and Documentation Guru. Take care and God bless.